What do you think? Shall we kickstart? Yeah, let's do it. Oh, big welcome to everyone, and thank you for signing in for the second community of practice. And today, the topic of today, very timely, we're going to be talking about seasonal triggers and thunderstorm asthma. Next slide, please. We'll start with the acknowledgement of country. In spirit of reconciliation, we acknowledge the traditional custodians of the lands on which we meet, and for us will be the Wurundjeri people of the Kulin Nation. We pay our respects to the elders, past and present, and extend that respect to all Aboriginals and Torres Strait Islander peoples today, for they are the safekeepers of memories, traditions, and culture. We recognise their connection to country, land, sea, and community, and the role in caring for and maintaining country over the thousands of years. May their strength and wisdom be with us today. Next slide, please. Okay, just a little bit of housekeeping. It would be very helpful if all the attendees stay muted, but you're very welcome to unmute yourself and ask questions and speak at any time. It is an informal meeting. If you're more comfortable, you're welcome to put your questions in the chat function. Please ensure that you sign in using the name that you register for the session. That's because the PHN will be taking attendance and providing you with the CPD points. Next slide, please. Oh, and this session will be recorded, so let us know if that's an issue, but the session is being recorded. Some instructions on how to change your name. Don't think there's a problem here. I think we're all good. Next slide, please. Accept the participant on iPhone, please. Thank you. All right, just a brief run through of the agenda. We'll just be going through really brief introductions. And then we'll be handing over to Christy for a recap of practice one, then going through to some data around the Inner West, and then going through our two expert speakers for tonight with discussions. Now, you're welcome to unmute yourself at any point to ask any questions or to provide any comments. Next slide, please. So just a little reminder, with the community of practice, we're a little bit different from a webinar. The purpose of this session is we're all experts in looking after children with asthma. The purpose of this is to share information and come together to learn from each other. Next slide, please. All right. So we'll actually start with the attendees first. If you wouldn't mind just putting into the chat box your name, your organization, and particularly your role in looking after children with asthma, please. I'm not sure whether it is my issue. Is anyone else seeing the chat messages going through?
Yeah, I've seen it now. Catherine, Belinda, Aaron's there.
Oh, yeah, it's coming
from
through.
Australia, yeah.
Yeah, perfect. Oh, good. Thanks, everyone. Great. It's
sorry, I was just a bit slow. I'm not that quick at typing.
That's all right, Aaron. We'll forgive you for that. And as you can see, we've got lots of experts online today, ranging from representative from Asthma Australia, Safer Care Victoria, Department of Health, CoHealth, Sunshine Hospital, welcome, community nurse educators, and nurses. So there's a wealth of experts online. So throw us any questions, we'll be able to address them. All right, so next question, please. So just introducing myself, I met some of you in the first community of practice. My name is Catherine Chen. I'm one of the pediatricians at the Royal Children's Hospital in Melbourne. I'm the clinical lead of the integration of care and community of practice part of this ICAM project. My research interest is in looking after children with asthma and how do we improve a more integrated model of care. Next, I'd like to introduce, if everyone remember, our lovely co-facilitator from the first community of practice, Dr. Kirsty Tamis. Kirsty is a general practitioner based in the northern suburbs. Am I correct, Kirsty?
Western, sorry. Yeah, slightly more west than the north.
She's originally from Scotland, and she has a diploma in child health and is interested in all aspects of general practice, but especially in chronic disease prevention, management, particularly asthma, child health, and elderly care. Next slide, please. So just introducing our experts for tonight that will be giving us a presentation. First, a big welcome to Dr. Aaron Chambers, who is also a general practitioner with a special interest in allergy and immunology. He has worked in general practice since 2006 and is a clinical director of Allergy First, based in Brisbane. He's passionate about family practice, including allergy, pediatrics, obstetric care. And Aaron serves as a GP liaison officer with the Children's Health Queensland-based and Queensland's Children's Hospital. He founded the Grow Life Medical Group and is co-founder of Allergy First, Cup Care, Pediatric Urgent Care and Telehealth platforms, GP Consults. The other speaker today is Dr. Danny Sutoros, which is leader of the ICAM project, Improving Childhood Asthma in the Inner West. He is also a general practitioner and a senior medical advisor in the Victorian Department of Health. Danny led the department's medical advice response to the 2016 thunderstorm asthma event, which is so far the most significant event of its kind in our recent history. Danny graduated from medicine in 1986 from Monash University, obtained a Master's of Public Health, and is a fellow of the Australasian Faculty of Public Health Medicine. So welcome, Danny. Next slide, please. All right, but before we go into the local data, I might hand it over to Kirsty just to reflect on our first community of practice.
Hi everyone, thank you so much for taking time out of your busy lives to come and join us this evening on a particularly hot and polleny night. Good time to refresh our knowledge. So the community of practice last session was kind of a test session for us. We went through adolescent asthma. And we had physicians from the Community of Asthma programme, the Royal Children's, we had pharmacists, GPs, asthma nurses. It was really great multidisciplinary conference, I suppose, to give us sort of idea around what we're looking here. We had great discussions about how everybody was working, and if you want to share your own experiences tonight, we would love to hear that. And it really led to a great understanding of, one, what our own roles are and how we can integrate the system to make asthma management more cohesive. Really good example of that. I don't see Naomi tonight, but I'll let her off the hook. Naomi Oborn from the Community Asthma Programme reached out afterwards saying how much she enjoyed the session, how useful it was, and she had some really great ideas for working into secondary care and primary care. Some ideas for educational videos that we could do for the Royal Children's Hospital for families struggling with asthma management, and also how to create more of an environment that would be open in general practice to multidisciplinary team meetings. So some really good conversations about that, and that's the sort of effect we're looking for. If anybody wants to share their stories at any time, any experiences, please do so. If you want a recording of last session's video, you can email in the post-session email and request that, or contact Safer Care Victoria. I don't know if anybody else was here from last time who found the session changed their practice, or has any stories they want to share verbally or in the chat of how it's helped them at all. I'm not going to pick on anybody. I can't see anybody that I'm specifically going to call on, but if there's at any point anybody wants to share something that they found was useful from last session or has changed their practice, please do so. Okay, if no one's coming forward just now, absolutely fine. I'll hand over to Rachel to explain a little bit about our local data and why we're doing this project.
Well, thanks, Kirsty. Can I get the next slide, Belinda? So my name is Rachel. I'm one of the clinical fellows at Safer Care Victoria, and my background is as a hospital pharmacist. So today I was just wanting to share with you all some data that we've pulled on emergency department presentations. So with the Improving Childhood Asthma Management Project, or ICAM as we more commonly refer to it, this project is focused on the inner west of Melbourne, so particularly 3 LGAs. So the data you see here is showing you the presentation rate of children living in the 3 LGAs, Brimbank, Hobsons Bay and Maribyrnong, all located in the inner west of Melbourne. So what you can see here is 4 different lines which represent 4 different age groups. So the blue line there is the 0 to 4 age. The orange line is the 5 to 10. The grey line there is 10 to 14, and then the yellow line there is the 15 to 19-year-olds. So what you can see here, and it's probably no surprise, is that the impact or the influence the different seasonal changes have. So early on in 2016 there in the yellow is when thunderstorm asthma hit in November 2016. So we can see here a massive peak that occurred in all age groups. We then can see the impact that winter has on pretty much all the age groups, but in particular the 0 to 4 age. We can see the influence of spring as well as the school. So returning back to school year, and we notice that at those times there are a rise in the number of presentations to emergency departments. Finally, we also wanted to capture the impact that the COVID lockdowns had. So during this period, we can see that in winter, we actually had a reduction in the number of presentations. And in Melbourne, that was mainly because everyone was in lockdown during this period. And then we can see here another peak, and this is when we came out of lockdown in November or around November 2020. So this is really just a snapshot to show you the local data and to just think about, I guess, what you see in practice. And it's probably no surprise to you all what you see here in this table. So I guess this links in, and I don't know if there's any points of discussion that anyone wants to put in. You can definitely put that in the chat. Otherwise, I will hand it over to Aaron Chambers, who will be presenting on seasonal asthma triggers.
But before you hand over, Rachel, that's awesome data. Does that, can you tease out asthma presentations there, or that's just all causes of presentation?
I can't, Belinda, do you know? If that, we use the coded.
We could further stratify it. So this is asthma and wheeze, combination of those 2 data sets. We could probably break it down if the data has been coded correctly when the patient's presented to emergency. We know that there's the further breakdown. So we could attempt to further break it down. But
yeah, because that orange line's really interesting me. You know, I wonder what's going to happen with that. Like it.
Yeah,
sort of looks like a trend, but yeah, we'll see.
Excellent. All right. So Aaron, I'll stop sharing so that you can pop your slides up if that's okay.
No worries.
Great.
Sounds good. Just trying to share my slides. I'll be with you.
I guess, were there any surprises from that data that people were curious about? Pretty self-explanatory, I think, isn't it? Yeah, perfect.
So Belinda, they were just pure, they were asthma presentations. They weren't
asthma and wheeze.
Asthma and wheeze, yeah,
yep.
Gotcha. And what were so there's peaks, so it was showing there's peaks in spring, there's peaks and return to school, and there's
our peaks in winter as well. And we also, we took the data back to capture that catastrophic event that we saw with the perfect storm for thunderstorm asthma that we saw in 2016. So really just to capture the emergency presentations in the local government areas that we're focusing on, which were consistent with that peak across the state. We looked at that as well.
Very good. So thank you very much for inviting me. I'm a GP from up in Queensland, so it's only 10 to 6 here. So I think it's a little bit later down there. So I've been asked to speak about paediatric seasonal asthma. I guess having a diploma of child health and being a practicing GP in a clinic with plenty of kids, and then being the director of Allergy First, which is a GP-led allergy clinic group in Brisbane and Sunshine Coast and Gold Coast that this is a topic that really, really interests me. And I see we haven't got a huge number of people. So I think the best thing that I learned, and congratulations, Kirsty, on chairing such an excellent dynamic group. If you've got stuff you'd like to talk about, I think that was the most valuable when we met up in preparing for this session. So just the discussion amongst the participants was the most interesting thing. So this isn't intended to be didactic, so please do jump in if you've got anything you want to bring up or discuss. The idea behind this is to really just prompt some thinking around considering the role of airborne allergen in seasonal asthma, and think about the entire airway, because this isn't just about your lungs. You've got a nose as well, and I think that's all too often forgotten. And really just to think about appropriately referring for allergy testing or desensitization where it might be indicated. The whole idea behind this being important is we still have a residual rate of mortality from asthma in Australia. And there's some figures that I saw from the ICAM website and also from some other data from the ABS where still 15 people under the age of 24 died in asthma in 2019. And there were 20 people in that younger age group who died in Victoria. And that I understand the whole reason this has been brought up is because you've got data showing there are more children in your area attending emergency due to asthma. And that underlying morbidity is a much bigger group than the mortality that's the tip of the iceberg. So we wonder what's going on, and you're not alone. I did a similar presentation in Adelaide where they've got a similar rate of high presentations north of Adelaide. So first of all, a question for everyone, and I'm not sure if we've got a poll or do you want to just pop in the chat? What do you think are the most common triggers for asthma?
People feel free to unmute or use the chat. Belinda's kicked us off with pollen.
For some reason, my mouse is not working, so I'll be relying on you to call that out, Kirsty, because I can't actually click on anything to see the results.
So we've got, a couple of votes for pollen, viruses, ryegraft, dust, smoke, more viral infections, hay fever, viral exercise. Yep.
Excellent. So viral respiratory infection is apparently number one. And remember, I'm a GP just like everyone else in the room, or most of the people in the room. So don't be too hard on me. But viral respiratory infection with rhinovirus predominant is supposed to be the highest cause, followed by allergen exposure, and then all the others. And I think they run sort of a bit similar to each other. But just remembering there are lots of common triggers, but both of them are very much upper airway diseases. So that's the kind of take-home message out of this slide, is that upper airway diseases definitely trigger lower respiratory allergy. And so this is just, I guess, a brief overview. I don't think we need to dwell on this around like what history you might take to kind of get an idea, but I guess the key things to think about is a child waking snotty every day? Are they having seasonal, sneeze and itch? Is their wheeze got a real seasonal pattern? And just taking that story, the whole idea behind this is kind of just really a bit of a checklist that I go through in order to think about the presentation, because once you get that information, it's all about the synthesis of it and thinking about, okay, if I ask some questions about geography or ask some questions about seasonality, it can completely open it up for you. So this is just for example, now this is Sydney data. I'm sorry, I couldn't find anything out of Melbourne, but this really just looks at the asthma admissions when mapped against the daily grass pollen counts. And you can see how there that sort of late, sort of spring to summer, there's a peak in the pollen count, and then there's kind of a lag and then a delayed increase in admissions for asthma. And I suspect that probably part of that may be made up for seasonal viruses, but the regressional analysis on this showed very clearly that the peaks in grass pollen account are then followed in a very predictable fashion by asthma admissions. And then really this is the slide that I want to kind of have just a general discussion around, and if you want to jump in, please get in. But this, I stole this off the reference down the bottom there, but it's so great at just illustrating how to think about synthesizing that history that you've taken. So when we're thinking about kids who are presenting to emergency and trying to do something about that, you could look at the viral infections at those peaks. And we know that you can change that. Like look at the COVID lockdowns, and you guys had it much harder in Melbourne than we did in Brisbane. But it does change things, and it reduces the rate of infection. And then it's, you can see that real suppression in that presentation to hospital through that phase. Now, the problem is when in real life, we know the cost to us socially and societally with those lockdowns. We can't really change that a lot, but all the things underlying are potentially changeable. So you can see those other layers. If you think about a patient who presents acutely in distress and coming to you in clinic, well, there's been a whole lot happening before they get to you that are potential ways to intervene. So that's, I guess, the key message here. Think about, is there, if the child comes in, they've got perennial symptoms and it's like all through the year, but then maybe punctuated by seasonal symptoms, you might think, well, okay, they might have house dust mite, which is the typical one. You kind of wake up, the child's snotty, they've lots of tissues by the bed will be the typical story, or they've got disrupted sleep, they're tired in the morning when they wake up and they're snotty. So that child is the classic story of house dust mite. So you can predictably, on the history, if you kind of ask enough of these questions, you'll recognise it, that's the story. And then they might say, well, and actually I'm really even worse in spring and summer, and typically that's grass pollen that kind of shoots up at that time of year, and then it could be even then punctuated by seasonal viral infections. So what we can do is look at the smoking status in the home, look at the house dust mite, look at their exposure to viral infection, and then other seasonal triggers, and then you can think over the 12 months beyond just thinking about the preventer and the reliever that you can put in there. You can actually think about what environmental things you can do about this, and that's I guess where I sometimes, like in a normal general practice environment, I find I tend not to think about it as much as when you're in a GP or special interest clinic, and that's why a group like this, I think, where you've got I saw Dean Tay is in the room, and paediatricians and GPs, that's where we can start to think outside the box. And get different ideas as to how to manage this. So
a few questions there, Aaron,
yeah,
just if that's okay. Really good point from Marianne. You might not have specific information on that, but talking about the environment and reversible changes, is there any data on climate change in the ozone and if that's affected pollen counts or asthma?
Oh, crikey. I mean, I can tell a story around an observation we made in the Gold Coast clinic where there was a flooding event there, where it was so fascinating. We had a lot of patients around that time coming in. Oops, I seem to have lost you. Am I still there?
Yeah, you're here.
Oh, good. Yeah, we had a whole lot of patients coming in around that time to get allergy testing, and the type of testing is a typical skin prick for pollen, that kind of stuff. A lot of them said, oh yeah, I just every year in spring and summer I get these bad symptoms, and I think of it, I haven't had them this year actually, and that was immediately after this flooding event. And then we held a whole nother different cohort coming in saying, look, I don't usually get allergy, but gee, it's bad in this season. And so we're presuming, we haven't got any data to back it up, but we're presuming that actually there's quite a change in the grass population, and that perhaps some people who had been allergic to whatever grass was kind of endemic at the time, there'd been a change in that, and then we're getting a different population coming in afterwards. So yeah, really interesting sort of anecdotal observation to kind of describe, I guess, what the potential effects of climate change could be. I guess for you in Melbourne, thunderstorms, which Dean will talk about later. Was that Dean?
Anybody else in the group have any evidence? I personally know nothing, but anybody else seen any data, maybe Dean, in the allergy sphere, anything about increasing, the allergies are increasing?
There is some sense that, with the change in climate, there could be change in plant growth, and that could be higher. And you just need to look at the grass this year with the change in the weather. And there's also a sense of, the allergenicity of each allergen. So each pollen might become more, contain more allergen, as it were. So we're expecting it to change and get worse with climate change, certainly. Whether it's related to ozone, that's a different thing, but certainly just straight up and down climate, movement of climate into new areas. So as the ecology changes, as the climate changes, we're going to be running into new things. And of course, then there's new crops and new plants being, coming and going and changing species.
Yeah, and Karen making a really good point there, just saying that the allergy season may not just be the sort of September to December that we see, it may be transitional. I've certainly noticed much more presentations over summer in the last few years. I don't know if anybody else has. Don't know if there's any data to support that. And
very interesting. I mean, that makes total logical sense in terms of in Queensland, we've got a triphasic sort of pollen count increase through spring and then into summer. So and if that, I guess, shifts south with a change in climate, it makes sense that you would have a really change in the distribution of presentations.
A really nice point from Belinda as well in terms of triggers, stress and anxiety. I suppose I don't see so many people with stress and anxiety triggering. I know we're focusing on allergy this time, but I suppose it's just a learning point for everybody to remember the overuse of Ventolin in stress and anxious children's and what I call cough tics. When you're coughing, because actually you're worried or you cough and then you get scared, especially children in the post-COVID world.
Actually, that's a good point, I think, around the cough. I think so often the cough comes when the upper airway is neglected, and a lot of cough is allergic rhinitis. And I think, addressing that and treating the upper airway, with something like Nasonex or whichever sort of nasal cortisone you want, at least a trial of treatment to see if it improves it. As long as you're sure there's no wheeze and the child's not got any respiratory distress, I think absolutely treating upper airway is so commonly a cause of that and warrants treatment. The way I get that across to parents is you can imagine if you're there, your nose has got a job, and that is that it's there to filter, warm and humidify the air, and getting across to them to say, look, if that's not working, your child is breathing dry, dusty, cold air directly down into their lungs. Of course, that's going to make them wheeze and have shortness of breath. And I think that tends to kind of cut through a little bit.
Yeah, absolutely. Dean's just put a really interesting link up there. Dean, I'm not sure we have time to look, and would you be able to give a summary of that? Do you know it well enough? Am I asking a lot?
I haven't read it. I saw this presented in a couple of conferences. And without a doubt that there has been a significant ecological change, and there's been some data that shows that climate change has resulted in longer pollen seasons, and other factors such as increasing heating of the world has resulted in increasing bushfires, which then subsequently results in increasing asthma. So I think it's a very complex ecosystem. But I thought, without a doubt, that's a great question, and I thought this is a little nice reference to have a look at. So without a doubt, there is a significant impact, and it's complex.
Yeah. Well,
Christine, may I go back a little bit to the anxiety part, if I may? I think the last session we spoke about adolescent asthma, and one of the tricky things with adolescents is trying to differentiate when the feeling of shortness of breath, is it anxiety or is it asthma? Because I think there's a risk of perhaps overdiagnosing or over-treating with asthma when in fact is anxiety. And I think it's interesting just to briefly touch on that point. It's obviously related and it can make asthma worse, but any sort of tricks that people here use to try to differentiate whether the symptoms are because is it asthma or are they anxious?
Have we got any respiratory physicians here? Because I think if we do, like just talking about spirometry in that circumstance, and looking at the flow volume loop, and that kind of, when it's anxiety and vocal cord dysfunction, they get that real flattening of the peak flow, and then compared to the kind of scallops sort of look of the of asthma. Is anyone here who can shed?
Yeah. I think objective data, one of the things, Colin Robertson's not here today. He was here in the last community of practice. He used to teach us in emergency, often we have to make a decision, emergency of to give Ventolin or actually to approach it a different way. He often say just look at how the patient breathes. So if you truly have asthma, your expiration phase, it's much longer. So you breathe in and then it takes longer to breathe out. But in anxiety, it's almost the opposite or equal. So and that's been quite useful at the end of the bed. And I don't know whether other people have other things that they use to help differentiate. I can find adolescents with asthma can be a little bit tricky with that.
I think that's a fantastic tool to use. And there is, I think sometimes in medicine, those untaught skills are the most valuable. You know, your gut feeling, does this look like a worried kid or an asthmatic kid? And it's very hard to quantify that. I would like to big up general practice at this moment, because I think we're best placed. We hopefully know our kids, we know their families, we know how they struggled in lockdown, we know their asthma education, and it's something I usually approach in sort of a nice, sensitive way, saying, you know, I've noticed you're coming in a lot, you often seem a bit worried, how are things going, and use that as a technique just to approach things like school. How did you find, especially post-COVID, how did you find going back to school and being told you were a high-risk kid and you're a priority for a vaccine and you have to make sure your asthma plan's up to date, and you know, and approaching it that way. And I just say that because obviously we are based in family care, so we might know the history that mum's got an anxiety disorder or has had an asthma attack and admitted as well, which sometimes you don't get the full picture if you just have a one-off asthma session in acute care.
Kirsty, I realised something's gone wrong on my end and I wasn't even sharing slides there, so I apologise for that. I do have a case if you'd like, if we need to promote discussion, but I think this is going pretty well, so I'll leave it with you.
Always open to cases, yeah, if you've got a good case. Would
anyone like a case? I've got a case just to talk through. It's more just to kind of, again, just provoke a bit of discussion. So let me try and share the screen again. And sorry, there's something sort of going a bit funny and haywire tonight with the screen, but we'll see how we go. Does that seem to be working?
Yeah.
So I did put up a thing, I'm not sure if this showed, but just talking around in the asthma handbook, they do talk about in the child who's got allergic rhinitis to think about desensitization if you can't avoid that allergen. So we were chatting the other week about down in Melbourne around that seasonal thunderstorm event. And for those people who did sort of present at that time, have you gone back and thought about doing allergy testing for rye on them? And I don't know if anyone has, but it's to me it'd be a relevant consideration. I'd at least consider it. Does anyone comment on that?
Comments up here. See, we have some of our amazing asthma nurses and community asthma program members here. Has anybody noticed that since the asthma event, an increase in allergies, or people suggesting allergy testing? Can't see any comments there. Dean,
that's fine.
Dean, is that something you recommend? Oh, Mel Richards has said definitely there. Yeah, okay.
In terms of post the thunderstorm, sorry, just didn't quite catch the question. Was it after the thunderstorm asthma event, the increasing need asking for desensitization? Is that correct?
Well, probably more, are they doing testing to find out, you know, are they definitely rye pollen allergic, or are they just kind of presuming they were because they presented on that day? And what action practices and everyone in Melbourne taking after that event to kind of proactively manage it in future?
Yeah, definitely. I mean, we're certainly at the Department of Allergy Immunology and also privately here in our group, you know, since the thunderstorm asthma event, there's been a market focus on looking for the factors that contribute to thunderstorm asthma, evolution of allergic rhinitis, and one to be on the front foot. We have a lot of patients and families whom are asking just keeping Ventolin and a spacer at home, just in case they get thunderstorm asthma. These are patients who've never had asthma because they've heard about the incidences of thunderstorm asthma in patients who've never experienced it. So absolutely a big focus here in Melbourne. And with the higher pollen counts that we've had over the last few weeks and over the last few years, it has definitely been a big focus. And rightly so, I think, to a certain degree, but maybe perhaps not the extreme and unhelpful steps that patients could take. But I suppose this is a great forum for us to discuss what are some of the simple stuff that it's cost effective that we can roll out, you know, in the front line, which is great to have this forum to discuss.
Dina, I think that's a really interesting point. There's lots of questions here about, you know, exactly echoing what you say. A lot of families are really concerned wanting to access testing. There's long waiting lists. I guess there's two questions here I wanted to ask you locally from Melbourne in terms of access and referral pathways. But then a second part of it, if you wouldn't mind addressing, we know there's waiting lists and costs. Is there other practical ways that GPs or families could tackle this before they land in your clinic or in the hospital?
Yeah, great question. And yeah, I see that the question's about costs. I think that the referral pathways at the moment for the Royal Children's Hospital Allergy Immunology Department is that we are triaging referrals for patients who have had severe allergic rhinitis. What we're looking for in a referral letter is that they've had really severe rhinitis and they've failed basically a decent course of nasal corticosteroid. In those patients who have fulfilled that, those are considered priority patients. Now, and I think that sort of lends itself well to sort of say some of the simple steps that could be done. And you know, my personal opinion is that many of them do not need to see a specialist allergist immunologist, and a big bulk of this can be handled out in a community just through great education and great understanding. And as Aaron has sort of stepped out there, a good degree of history taking and some simple testing that can be done in the community, just basically through a blood test. So I think that if we could upskill all GPs, I think it would be as simple as really if the patient did or didn't have asthma, but it suddenly had allergic rhinitis, be aware, number one, that majority of patients do underdetect how bad their rhinitis are and generally undertreat them. So being mindful of that is the majority of patients, and often the parents will say, oh, they've just got a slight snotty nose, it's not that bad. But if they do flag that actually it is a bit troublesome, that probably indicates that it's actually quite troublesome. So pay attention to that sort of history. And then a specific IgE testing or blood RAS testing used to be called, they're no longer radiologic sorbent, but getting a total IgE and running a specific IgE to ryegrass pollen, plus or minus dust mite, depending on that, as Aaron has sort of stated, if there's a pretty good history of perennial symptoms all year round, then running a dust mite test would be helpful. And if you've got a patient who's got true allergic rhinitis plus troublesome, plus a specific IgE that's positive ryegrass pollen, immediately escalate them to start using a nasal corticosteroid spray. And in 9 out of 10 patients, that's all that needs to be done. They start using a mometasone-based nasal spray over the counter at optimal dosing from August through to February when ryegrass pollen pollinates. 9 out of 10 patients, that will improve the symptoms dramatically, and they will then also at reduced risk of thunderstorm asthma. The next point of escalation is really just adding a non-sedating antihistamine, and to be unafraid to give bigger doses. So you can often double the doses of a second generation antihistamine, such as loratadine or fexofenadine. And that will be very effective. And then the other thing that has come out in the new rhinitis guidelines at the United States in 2020 was just having a low threshold of adding an intranasal antihistamine. So they can, on top of it, using an intranasal corticosteroid, that's really effective. It really dampening down the rhinitis symptoms. So that means like intranasal azolastine, which you can buy over the counter from the community pharmacy. Or in Australia, there's 2 combination intranasal steroid and antihistamine nasal spray. So between 6 to 11, they can only use one. And I guess I can say the brand name because there's only one, that's Ryaltris. And then from 12, over the age of 12, there's only 2 combination intranasal antihistamine and steroid, and that's Dymista and Ryaltris. They're excellent products. In terms of the clinical guidelines, it's very clear that using combination intranasal steroid plus intranasal antihistamines are highly effective in controlling rhinitis symptoms. And we know that if we control rhinitis symptoms, the asthma exacerbation rates goes down, especially if you've got pollen-induced asthma. So 90% of patients can be really well managed in the community, and they can do a great job. And getting the specific IgE to grass pollen will give them that diagnostic certainty and definitive way to treat going forwards.
Yeah, I always think it comes down as well, like anything, it comes down to compliance and using the medicine correctly. And I think all patients who start on plain old mometasone, like mostly I don't tend to start them on Ryaltris or Dymista because they're a lot more expensive. And Nasonex is so cheap now, it's like you can get sometimes $8 or $10 at the big chain stores. But I think so often they don't persist because they don't notice the benefit because they're not using it correctly, and they're just spraying straight up like this. And every single patient I say, look, you've got to look down at the floor and make sure you're spraying up towards your earlobe so that they actually get proper intranasal cortisone. Because I think it's a really common issue that they just spray it in the front, they don't really get a good delivery, and then they don't experience the benefit. So you make sure you're coaching patients on that. I think it's important.
I think Belinda's making a really good comment there. Thank you so much for that, Dean. I've just taken a whole load of notes. Belinda's making a great comment there about children and nasal sprays. I don't know if anybody's given their child a nasal spray, but things like that, a bit like the inhaler, it's sometimes useful to bring them in, or, you know, the first subcut injection, and just say, just pop into the pharmacy, bring it back, let's do this together, and think of all your tips and tricks. From the paediatricians or the asthma nurses, I don't know how much of the antihistamine and nasal rhinitis you do in asthma clinic, but does anybody have good tips or tricks, fun ways to get kids to take a nasal spray for 4 months?
There's quite a useful resources. Some of my colleagues at a children's hospital have put together a video of how to use a nasal spray. As everyone pointed out, technique, just like asthma, is so important. And I think, as what Erin has said, pointing it towards the ear prevents a lot of blood noses. You know, sometimes we see a lot of children stopping it because they have blood noses, but pointing it away from the middle really stops a lot of blood noses. I just wanted to ask both Erin and Dean your experience about the younger children. Often we're seeing a lot more younger children, preschoolers or early primary school, with symptoms. And I think finding a nasal spray that suits them can be tricky, and whether you have tricks or advice about the younger children with allergic rhinitis.
Oh, look, I'm probably only speaking from experience as being a father. The best thing I ever did was with my son was give him one of those squirty high flow saline things and get him to start using it himself. And at first he was like, oh yeah, but actually he started to realize, oh, hang on, this works. And it sort of almost got him used to it. And then he was quite happy to start micromomedazole after that. So I think they don't mind the saline so much, and when they get the snot out, they blow it out, they feel excellent. And then that actually helps, because then you've not got all this snot that's kind of catching the mometasone before it hits the mucosa. So I think that's a tip that seems to work.
Yeah, I agree. I think that sometimes when the families do not succeed is when the mother or dad is administering for the patient and they don't know when that little hit is going to come that nose. So I totally agree with you. Letting the child do it themselves, they know when to do it, they know how to angle it. I think that is the best chance of success. And then just give them time. Like, you know, there's a difference between trying when they're 3 years old versus 6 months later. Kids forget very quickly, and when they see adults doing it and they see their older siblings doing it, then they pick up and say, oh, okay, it's maybe not as big a deal as I thought it was going to be. It's like maybe it might be easier than eating broccoli. I don't know. It might be along the same degree of challenges. And sometimes it's, you know, one of those things where, you know, that it's so bad that we sort of say to the parent that, well, you know, sometimes adults do things that we don't like doing as well, but we do it anyway. And one of those hard lines.
In the spirit of this being an ICAM to change practice, I am just looking about the way I look for additional information as opposed to picking up the phone when I'm struggling with a patient. I know Health Pathways is obviously one of us pre-referral, but I use the RCH clinical guidelines, and I just logged on there to have a look at it, and it's great. Says everything that you have said. I'm just wondering if anyone from the PHN can say if the Health Pathways pre-referral is in depth. Sometimes I find Health Pathways a little bit clunkier, doesn't have quite that specific information. Does anybody know about the Health Pathways advice for pre-referral for asthmatic kids with allergic rhinitis? Nope. I wonder if that's something, again, for us working in the community, that we can just kind of take a mental note to signpost for. I often give parents sort of get them to get it up on their phone, the RCH clinical practice guidelines, saves me sort of writing it all out for them and to refer to. So how much do I'd be interested to know how much the asthma nurses get involved in allergy and give advice on that. We've had some really good input from community asthma services from Melanie and Libby and Narelle. Is anybody there? Does anybody there talk about allergy a lot? Do you have resources that you use that are useful?
Kirsty, I think Yvonne from the Northwest PHN might have had an answer to the previous question as well.
Oh, goodness. Right. Okay.
No, hello, this is Yvonne at back end. No, I was going to say I've taken a note down to make sure that we will be looking at the pathways. So we can come back in the December session and have an answer.
And maybe even linking it to those RCH clinical guidelines, because it even has a link to the technique for nasal spray, which is, yeah, sort of invaluable.
Because he has a really good point, because all the referrals from the community regarding a block-nosed or snoring goes either to the allergy team or the upper airways in general medicine. And because of a very high waiting list, we do go into details of what you put on that referral. So if you haven't put things like you have tried a decent, when I meant decent, I mean months is what Dean say, of intranasal steroids, often they are rejected.
Yeah.
And therefore putting in details what you have tried and what has been tried, it's so important just to get your referral through.
Yeah, absolutely.
Whilst we're talking actually about managing upper airway and then potentially referring, that we did a little case series, and I think this is backed up by some other data that's published, is in the ones who are so severe that they're kind of ending up like looking at desensitization, for allergic rhinitis we're talking about, about 50% of those patients have asthma, and of our series, about 50% were undiagnosed. So that means that and it was probably slightly below 50%, it wasn't much below, but that means that a good chunk of the kids who are presenting and they don't even know they've got asthma, but they're presenting with upper airway issues, they actually have underlying asthma. And so it's just an important thing about thinking about case finding. If you've got a kid you're managing with just particularly significant allergic rhinitis, think about have they actually got asthma, and make sure you're managing that as well.
Yeah. Mel and Libby telling us the resources that they from the ACIA. And just asking you guys as well, do you find a lot of undiagnosed or undertreated allergic rhinitis that you're referring back to primary care? Like, what ways or pathways would you contact a GP to say, actually, we kind of talked through the asthma, it's great, but we don't think their allergies are controlled? Is that something that you've had experience of, that you've done, that you can think of a case?
I usually send a letter out to the GP. And I also just say the symptoms that they've had, like nighttime coughing, only at nighttime, no interval symptoms, mum states runny nose, or child's got that clearing of their throat all the time.
Yeah.
That's often, and then I'll just mention that to the GP, and also then send the link to, resources, and asking, I don't want to tell the GP what to do, but I just sort of say,
you're specialist.
I think this child might benefit from your expertise, assessment in regards to allergic rhinitis.
Yeah, I think that's brilliant. You're a specialist in asthma, and not every GP specialises in asthma. A lot of people are into gynae. They see women, they don't see paediatrics. It might just not be at the top of their head. Maybe they don't work in West Melbourne where everybody's got an allergy. But in the same way, I wouldn't feel put out if a consultant told me something I already know. They don't know my knowledge. You don't know the GP's knowledge. So at worst, you're telling something they know, and it's been a refresher in their head. And at best, they have no idea that the Royal Children's have that guidelines. I saw a child who meets this criteria exactly: anaphylaxis, asthma, terrible allergic rhinitis, seen by somebody else, referred to the allergy service because they had a total IgE of about 3,000 and very high to every grass and pollen. They weren't on nasal steroids, so it got bumped, so whoever the GP was that referred them could have really done with that resource. So yeah, please do educate us.
The other thing that I think some families are immediately concerned, in fact, probably useful to know that every single family is concerned about is the steroid side effects. And just to preempt that, to say that right up front, that obviously as health professionals, we are concerned about unnecessary overuse of steroids, but what we're concerned about is the systemic side effects of oral steroids. But the data on nasal steroid use and the lack of growth side effects is very, very good. I mean, for example, Avamis, I think it's been used from 2 and above for 1 year in a row. Daily use for 1 year did not result in any degree of any issues. And for, I think, mometazone, it was used in children 7 and over, and continuous use on a daily basis for 2 years. There was no issue with HbA suppression or osteoporosis or any steroid side effects. So flagging to them right up front, that's very different oral steroids, I think, will help improve with adherence as well.
That's great. I think Rachel's flagged. Oh, sorry, Catherine.
Oh, I was going to say, I think we're probably saying the same thing about Rachel's flagging. We just have 40 minutes left. In the interest of time, just wondering, just maybe a few lines about, should we be considering desensitizations and access to that? And then perhaps we can move on to thunderstorm asthma.
No worries. Well, shall I pop up this case? I can't recall if this, we'll find out actually. I can't recall if the case talks about that or not, but it'll come up at the end, I suspect. So I'll just share my screen again. So hopefully you can see this. I'm not going to do it up to the full screen because that seemed to fail last time. So so this is about Jade. She's 14 and presents with chronic cough, which has lasted for more than 3 months. She's got a history of having been diagnosed with asthma at age 4. No one smokes in the family. She's taking her Symbicort and describes this cough as worse at night and wonders, oh, doc, is my asthma flaring up? And everyone has noticed it so much that they keep on telling her to come and see the doctor. So so that's Jade. It's a pretty typical case, I guess you would see. Who'd like to give a stab at what the differential is? And I guess we've kind of we've talked so much about this that everyone's going to get this now, but maybe we'll skip over that. But if you want to put it in chat, feel free. Does anyone want to jump on the spot and give their 2 cents worth? No, we'll just move on. So I think it's reasonable for any of those, but
it's a lot of 1 and 3.
Yeah, 1 and 3. That's exactly where it should. And what would you do next? Well, as we've talked about back in that key slide, now remembering this slide, really try and keep that idea or concept in your mind when you're taking history from this patient, because it's going to help you. Also, the one that I didn't point out before is that geographic change. So, if they've been in Melbourne and they come up to Brisbane and suddenly it's all better at the fantastic beaches and stuff we've got up here, well, that also gives you a clue that it may be an environmental exposure. So go back to this. So make sure that the technique's good, ask about those triggers, and do spirometry. Who would do spirometry? And I guess, are we encouraging spirometry and trying to get it done more? Or I think it's done probably a lot less than it should be. Probably Medicare rebates don't help that picture.
Linda said the 6+ age group.
Yeah, but it is hard. Well, yeah, even 6. I find it even 6 to 8 year olds are hard. They start to get better from 8, I think. So her story is that she seems to be using her inhaler well. You've made sure that she's using the Symbicort correctly. I have seen a patient who spent years and years blowing into their Symbicort, and I took one day, just checked and blowing into it. So just, make sure you really do the basics, and that point before about getting to bring it in. Otherwise, you kind of go through, and she's got this kind of nocturnal history and perennial sneezing and worse on windy days in summer and winter. So hopefully that's giving you some clues around what might be causing this. And then you examine her chest and it's normal. She hasn't got any wheeze, but you have a look in her nose, which we also don't do as much as we probably should. And you do note that she's got quite a few nasal polyps. And you start her on mometazone and ask her to see her in a month and see how she's going. And we sent her off for skin prick testing because it's relatively available, but it sounds like maybe that's not as available, and maybe the serum-specific IgEs more recommended in Melbourne. So she came back, turned out that she's got a bunch of grass and dust mite allergy, so that fits with that story of perennial symptoms punctuated by seasonal symptoms and kind of illustrates that common pattern. And sometimes this is really impressive that they notice the quality of life improvement because they can smell. So I've had multiple patients where they didn't even realize they couldn't smell, and you start them on a nasal cortisone and suddenly they say, oh, actually, I feel a lot better, and better daytime alertness and all that kind of stuff. And so I guess it's in that patient, like exactly, I think the question that you asked, Kirsty, was around, when, or maybe it was Catherine, when should you consider desensitization? What does it involve? Is that the question? Yeah. So I think really allergy is pretty good because you can step off at any point that suits the patient. Like there's no compulsion to do this. I think probably in the younger child, and I know the GINA guidelines are now looking at this in their next phase that's coming around what's the role of early desensitization, because the kid with asthma and their house dust mite sensitized, they've got an enormously increased risk of asthma. I think it's 32-fold, approximately, something like that. And early desensitization does make a difference for them in that they haven't shown that it prevents the onset of asthma, although they're kind of wondering about that question, but they have shown that it definitely reduces their need for medication and the severity of their asthma presentations. So, and the earlier they start, potentially the longer the lifelong benefit. So I'll be thinking about it in that group. And then the other group is the one who you've tried everything, you've gotten them all the way up to like maximal treatment that they can tolerate. And, you know, so some form of an antihistamine, be it intranasal or oral, and it's a lot cheaper still for most people to take orally, plus a nasal cortisone and, you know, something like mometasone, because it's cheapest. That's the cheapest thing to do for the family who's going to struggle to pay for those more expensive combo ones. And then once you're doing that, you're flushing their nose with saline before you do it, and you're using their asthma puffer. If they're still having symptoms, like, I think it's reasonable then to consider referring off for consideration of desensitization. I think that's a pretty reasonable patient. Or I think there are some economic benefits in the long term. So that's probably a rough guide, as, you know, if you kind of think about it in the private world, I think that's what you would do. Clearly public services often are much harder, and I don't know what the criteria are there, but Dean, would you concur with that general approach if you think about it from a general practitioner's point of view as to who to select to kind of refer on to do this?
Yeah, 100% agree. I think that the initial trial of nasal steroid sprays and outlining to patients about the cost benefits of immunotherapy is a worthwhile discussion. I think publicly, I think one comment will be maybe what I see that comes through the referrals that could be done is just a longer trial of nasal steroid sprays, because once they see the kids are so much better, then they can see that actually, right, I've got something really cheap that I can access over the counter. I don't need any sort of any specific medical person overseeing any the season to season need to use, and my child is really doing really well with a cheap over-the-counter medication. And 9 times out of 10, just a really good course of the nasal steroid sprays to show effectivity is all that needs to be done. In fact, commencement of desensitization, even in those who come to our clinic, is actually a very small percentage. And then there are those who absolutely will benefit from it. And for us, it's just trying to help them see the long game, because even if, as you have said, Aaron, there are definitely economic downstream effects, but it's sometimes hard to help them see that, and for us to sort of help show them that if in the next 10 or 20 years they did receive desensitization, you overall get a 50% reduction in medication use, 50% reduction in clinical symptoms, and, you know, it absolutely something should be considered. Might not be right for everyone, but certainly for a proportion of patients.
Can
I just start? Oh, sorry, Kirsty.
I was just going to, sorry, Narelle, I don't want to interrupt you asking your question. I just wondered how much it does cost.
Yeah, I was going to ask what it costs now, because when I was in primary care in the eastern suburbs of Melbourne, we did a lot of skin prick testing. I haven't been in primary care for 3 years now, but we did a lot of skin prick testing on adults and children, which was horrible. And also a lot of desensitization subcut. And I remember one particular girl, she used to come, I probably saw her for 4 years. She'd only get her injection from me. Sometimes, some weeks it would take an hour with her. Sometimes it would take 5 minutes, depending on what sort of mood she was in the day and how prepared she was for her injection. But is sublingual sort of increasing, do you think, now? Because obviously it's a big commitment for families, and
it is becoming more available. Yep, it is a little more expensive, the sublingual preparations, and I think the biggest problem actually is compliance, in that, like, for some reason people don't mind turning up monthly to get their injection, but they forget to use the sublingual, and then they just don't get the benefit. I think that's the biggest difference. And so I think, you know, I guess we have a slightly different population, because we're kind of this mid-tier thing that's like bulk standard GP level allergy, and people who are seeking desensitization but haven't got a high level of complexity. And also because it's an economically cheaper thing to do, we probably have a group who are self-selecting to find the cheapest service so they get the cheapest access. And that group, they tend to choose the subcutaneous once they're given the options, because it's cheaper. and that's, you know, the compliance thing. I think they kind of go, oh yeah, I'll forget to do that, but I'll turn up to my GP monthly. So I guess that they're the considerations. I think it is going to get more difficult. Historically, like 5 years ago, everyone you sent back to the regular GP for desensitisation, they would be bulk billed for the desensitisation, and that's starting to change, and that's going to change the cost parameter for it, because if everyone stops bulk billing the desensitisation injections, that's going to be really difficult and quite a big burden on families. So I'm concerned about that, as I am broadly across the general practice sector. It's really difficult. Yeah.
I'm very conscious of time now and leaving some space for thunderstorm asthma. I don't know if you agree, Catherine, because I think we could talk about this. It seems like it's been a brilliant discussion all night. Is there anything else pressing that anybody wants to sort of bring up?
I think if Erin and Dean wouldn't mind staying on, perhaps there might be some time for further discussions, and maybe also related to thunderstorm asthma. So if we could just hand it over to Danny, and then if Dean and Erin happy to stay on, we can have further discussions later.
Fantastic.
Okay, thanks. The slides looked, the slides look different from this afternoon. So thank you, and yes, brilliant discussion earlier today. So hopefully this will be as engaging as and interesting. And I don't know, I might be talking to lots of people who have had first-hand experience of the 2016 event and could probably tell me some stuff. So maybe that would be useful to, you know, if someone has those experiences, love to hear them. We did have a big national conference the following February or March, I think it was, and we heard all sorts of stories from pharmacists and GPs, specialists, EDs, AMBOs, the whole lot. But I'm sure there are more stories out there to be told and heard. Anyway, you probably know that the 2016 event was the biggest ever epidemic thunderstorm asthma event in the world. You know, it was big, and it wasn't just that, you know, the numbers were big, it's the onset and the rapid rise in the demand. And that sort of stuff is really, really hard for systems to manage, because you can go over a hump, you can probably go over a big hump, you could probably do a long hump, but a really steep demand for something like breathing, where if you don't breathe for long, you die, like it's really tricky. I guess we've put lots of effort into trying to deal with this issue. Certainly, it wasn't anything that was on our radar. We'd never exercised this or thought about it really. And the impact was from Geelong, you know, right on Melbourne, like Melbourne and Geelong, but it did go from Ballarat over to Warragul. And I guess one of the things is that, you know, if something like this can happen, or did happen, so this is, you know, it actually happened, what does that mean in terms of, is it going to happen again? When's it going to happen? Why did it increase so much? And is that increase still going up? You know, are we going to get a bigger one? How often? Like it's been 6 years, and there's been little bumps, none of these big ones. And of course, we like to say that there hasn't been a big one because of all our intervention, but how would you know? Next slide. So what happened? One of the theories is from a famous respiratory physician is that you know, Europeans came over to Australia. They brought their little sheep, and the sheep ate all the native grasses, and of course we sowed new grasses and we sowed ryegrass, and there's a ton of ryegrass out there. And the three maps that you see, you can't see my cursor, can you? No, pity. The three maps, thank you. The three maps that you see are how much grass essentially there was and across different years. And on the right was 2016, and then the 2 years beforehand. So 2015, there wasn't much grass, there wasn't much pollen. 2016, you would think it was a massive pollen year, but if you just go to the graph below, you see the cumulative pollen counts. So it was below average up until sort of middle of November. It was about average, and then it didn't progress. Asthma admissions, up until that event, maybe a little bit more than average. So nothing to see really. Then there was this hot day. We hit the mid 30s. And next slide, please. And then there we go. And then the storm came in. As we know, we get those big hot days, and you'll see that the storm lines up, and it formed this particular convergence line where different air masses come together. And what happens is that with the masses coming together, you can get little particles, particularly insects, that can be picked up on radar, and that's how the bomb picks up these convergence lines. And it seems like convergence lines are really important in the mechanism of thunderstorm asthma. So this was the thing that came across. It went across in about an hour and a half, and it went across all of Melbourne. Next slide, please.
Danny, is it unusual for storms to come from the northwest in Melbourne? Because being a Queenslander, I don't know much, but they seem to come from the ocean. No, they don't do that.
No. Classic. Geelong gets hit and then it moves across. That said, we had a storm come down from the north, and we saw little blips go up just as the storm wasn't huge, but we can see those things. But predominantly coming across from west to east, and we're thinking that it captures the pasture lands, drags it along. So here are 6 little graphs, and you don't need to see the numbers. What on the first 2 you can see sort of a baseline, and the first one is ESTA. That's our emergency services telecommunications sort of service, or 000. And the line at the bottom is what they expect, and they have a specific analyst who spends all his time trying to figure out how much demand they have to match their resources, because of course you've got to have that matched tightly. We're seeing what happens with COVID and stuff, but they've been doing that for a long time, and of course there's a bit of give, but if you can see that rise in demand, all of a sudden those staff were heavily traumatized by what they went through that night. They'll talk about new calls every 5 seconds, and people struggling to breathe. Moving over is Ambulance Victoria, baseline, what they expected, and the bang, what happened. The next graph, the third one, with the shaded bits, this is ED presentations for respiratory, and what you can see is the shaded out area is what was expected. So that's what we expect. It goes up during the day, shrinks that down overnight, and then goes back up again. And the top graph, the top little curve, is asthma or respiratory illness presentations. And you can see, that's the one, thank you. You can see it goes bang. It goes all the way up very quickly. The next one down is this thing called nil diagnosis. And it's like, what's nil diagnosis? This is looking at the VEMD data, the Victorian Emergency Minimum Dataset data. Nil diagnosis is people who go in, get seen, but no one writes a diagnosis because they disappear. And what that reflects is a mountain of people coming in, they're seen and they're treated, but the clinicians don't have time to fill out the paperwork and say, this was asthma, and these people have gone. And so if you add those things up, and you can see how it progresses, the respiratory illness progress into the following day. The next graph is admissions. So again, bang, almost 500, this is excess admissions. And going back to the ED, if you add up respiratory and nil diagnosis, you're looking at almost 3,500 excess admissions in 30 hours. That's a ton of people, and there's a lot right at the beginning. Then if you go below, there was 30 excess ICU admissions, and of course any one of those could have died, and there was unfortunately 10 deaths. So, big bang, monster event. Next slide, please. And so what is it all about? And we're thinking that, we're thinking it's ryegrass, and we're thinking that essentially there's lots of ryegrass. You get this big, hot, warm, sunny day. The flowers open up, lots of pollen in the air. On the 21st of November, the pollen count was 102, which is in the extreme level. So there's lots of pollen, and then this type of storm, a particular type of storm comes along, and it sort of gets the pollen up, draws it up into the cloud. One theory is the moisture in the cloud swirls the pollen. You've probably heard of osmotic shock. And then the pollens burst. And if you see that EM on, yep, that's the one, thank you. You see these little starch granules, and someone's estimated that there's possibly 700 of those starch granules per pollen grain. So we have many orders of magnitude increase. So you might have high pollen, and then if they burst, and lots of them, then you have all these allergens. And the thing is that this storm can lead to a front, and it concentrates the allergens, and then it moves across and across a huge geographical space. So hence so many people get affected because of the nature of the storm. And this happens before the rain. So we're thinking it's in the wind gusts that precede the thunderstorms. So, and that goes to part of our messaging. Next slide, please. So, we were trying to think, how does this work? How do we intervene? And this is just a little simple model. If you start, I don't know who's holding the cursor, but yeah, if you could go to the top, you have a bunch of people in the community. A percentage of them are susceptible, and we know lots of people have hay fever or latent asthma. They get an exposure, and then either they can self-manage, and if they don't, they end up at a GP, or they call an ambulance, or they go to an ED. Hopefully they recover, and then around they go. And of course, we've got, this high grass pollen, we've got these thunderstorms. Is there anything else? Is there other secret sauce? People have said, maybe it's lightning, maybe it's ozone, maybe it's something else, maybe it's spores. We don't have strong evidence for any of those. So we're really thinking it's ryegrass, and we're really thinking it's a type of thunderstorm. There might be more to come, but at this point, that's what we're thinking. Next slide, please. And of course, this sort of model is, what happens to patients and community members. But this all happens in a social narrative, or in a setting, in a culture where people have certain behaviours. So if I liken it to heat waves, if you live in on the equator, you know what heat is, you know what to do. You don't go out in the middle of the day. And so was there a cultural narrative available to the community to say, oh, it's a hot, stormy day, big storm's coming, it's springtime, I'm going to go inside? No one knew that. So there was no cultural knowledge to draw upon. And certainly the institutional arrangements to respond to something this big were not there. And the other thing that's scaring us that was raised just before is what's happening to the regional ecology. Are storms getting bigger? Yes, they are. Thank you, climate change. Does this mean that these events are going to be bigger and stronger and more catastrophic? Again, is there going to be more grass? Is the pollen going to be more allergenic? And then what else is going to be thrown into the mix? Maybe there's going to be smoke from bushfires before the storm comes, or what have you. But certainly, I guess, in a kooky way, thunderstorm asthma has sort of, we got a bit of money, and we've got a bit of interest in the department, and we were able to really get this emergency rapid escalation process in the system, and it's ongoing. And with COVID coming, you know, there's lots of innovation happening within the systems, which is really good, you know, very reassuring. Next slide, please. So, you know, these are the places that we've intervened, you know, reduce susceptibility, reduce exposure, increase self-management, increase capacity in primary care and the ambulance. And of course, we've got a forecast. We've got a new monitoring and early detection system. And then we've got an advice and warning system that, you know, plugs into what usually happens with the fireys or, you know, yeah, emergency services. So I'll quickly just really run through them really quickly. So next slide, please. So, yep, and next slide. So in terms of individuals, essentially, certainly in 2017, 2018, we were, you know, all we could do was talk thunderstorm asthma. So raising community awareness, you know, riding on the coattails of this disaster that, yes, this is a disaster, this is important, pay attention, learn as much as you can. So we joined with a whole bunch of people, particularly the asthma orgs, who were fantastic. Askia was fantastic. And we developed a bunch of products and did the usual stuff that you would expect. And I don't know if we've got time, but we've got a little video that we could share, even if it's on the next slide. You could get a feel, if you haven't seen it, to what we did. And, you know, it wasn't fantastic, but it's what we could cobble together really quickly because, oh, the music's the best part. They're the little pollens. Oh, there's no music. We actually, when COVID came, we weren't allowed to, we had problems with our comms because the pollen looked too close to COVID virus. So COVID really made it tricky, but COVID has brought masks and COVID has brought all sorts of other things. Anyway, we did a whole lot of community, you know, stuff for the community, as well as going out and having a whole bunch of meetings with community members who were traumatized and, you know, had a big impact on them. Others, you know, had family members or people they knew who died. Of course, we provided stuff for health professionals. You know, we worked with NAC to get the ETSA info paper, which has just been revised of late. There's a whole bunch of education programs. We work with the RACGP. So if you haven't seen them, they're all sitting there. There was a bunch of webinars, so it wasn't just GPs, but pharmacists and practice nurses, because this really is, everyone's got to put their shoulder to the wheel. We built a pharmacy checklist with Askia or NAC, or I think that was Askia actually. And partly our linking with the pharmacy was to funnel people who have seasonal hay fever to ask the question, could you have asthma? So as you're saying, Aaron, a whole bunch of people with hay fever have asthma and they don't know it and they're at risk. So we worked hard to see if pharmacists could ask that question and then funnel them to their local GP. And also to get GPs to think about, well, you got hay fever, do you wheeze? Do you have other symptoms? Next slide, please. Okay, so to reduce exposure, this is sort of could be really common sense. Next slide, please. And this is about just, you know, don't get exposed to those allergens. So avoid the wind gusts before the storms. You know, and you could just have that as a general rule from October to December. You know, but we also have a forecast. But if we could have out as general, you know, general wisdom, you know, there's a hot day, there's a thunderstorm coming. Let's not stay out in the park, or let's get prepared. So we tell our line is, you know, avoid the storms, go indoors, and of course shut your doors and windows. And if you have evaporative air conditioners, turn them off, because what they do is they suck air from outside and dump it right on your head. You know, split systems, they're okay. They don't bring the air from outside in. They're like refrigerators. So you don't need lots of technology. You just need this cultural narrative, you know, just common sense. Yeah, common sense. We know, we're Victorians, this is what we do. Of course, we have people who come and visit and all that, but, you know, they'll interact with people.
Danny, could I ask a question there? This is absolutely fascinating. I feel like I'm in stunned silence taking this all in. In terms of narrative, what things have been looked at, what things have been done, and forgive my ignorance, in terms of getting, especially a Victorian national narrative? I certainly have never seen storms anywhere in the world like here, the way they rip through. And on that night, that was exactly what it was. It was a stop in the tracks while you're consulting what's actually happening outside sort of storm, which occurs occasionally, but I've not seen one since quite like that. Is there anything like a public advertising campaign? Certainly we've had lots with COVID, there seems to be resources and things there, but was anything like that done on
yes,
radio or TV?
Initially we get more money, and then COVID came, and then it was, well, people are not that in, COVID's the big game. And of course, there's getting, communities won't receive messages if there's too many messages. It's sort of that comms thing. But every pre-season, we have a campaign that we run. We work with the asthma orgs. There's Asthma Week at spring. So that's one of the things that we use to launch. And then when the forecast starts, so the idea is spring, get people thinking about it. It's spring, is a bit of a spring in your step, like you can do stuff. And then October comes, the forecast turns on, the next opportunity to get to the community. And of course, people like Melbourne Pollen, the guys from Melbourne University, which do have they're the ones who help with the forecast. They're out talking as much as they can about, pollen and, allergies, asthma. And then, of course, because of the forecast, it's a thunderstorm asthma forecast. The thing we're trying to do in terms of narrative is, our expert clinical group, we're keen on making sure that by the time there's the footy grand final, so use the football grand final as your yardstick. Everyone should be prepared. They should be on there inhaled corticosteroids, and trying to attach it there. So we've got to keep pushing the message out. Advertising's really hard. It costs lots of money to go on telly, and there's lots of other things to go on. So, sorry, over to you.
No, I was just thinking in terms of Catherine's telling us 5 minutes left, in terms of practical things, because obviously this is what this is all about. We could do the PHN. I see a lot of things coming through just as a GP, and again, forgive my ignorance if there's been there. I get about 40,000 emails a day with advice and updates and various subjects. And I know there's all the thunderstorm asthma webinars and things that we can do. Is there something that the PHN puts out or could put out in Melbourne in terms of resources, like a poster pack or something at the beginning of every September to say this is a checklist, exactly like Danny's talking about? Come indoors on high wind days, make sure your hay fever is treated. If you have a persistent cough, speak to your GP. Is there a checklist? Would that be a feasible thing that the PHN that could send out by email to GP practices or pharmacies in the area?
Yeah, so we as part of our seasonal campaign, we have a campaign toolkit that we send out to every man and his dog, organisation-wise. So all the PHNs, every way we can get the message out, but we go to organisations. The department doesn't go to GPs, if that makes sense. And then we leave it up to PHNs to tailor it and package it and send it on. But there's a ton of stuff including translated materials on, the health.vic website. And, there's a million things. There's videos, there's lots of things there. And a GP checklist. Now, what we've done, we've got 2 minutes, so I've got a ton of slides, but I don't know where to go. But certainly, right from the beginning, we did an ED checklist to make sure that EDs were prepared. And with COVID, and more recently, there's been these GP respiratory clinics. Knowing that these events tend to happen in the evening, so a bunch of GPs will be closed. And, what we sort of, no, let me go back. GP respiratory clinics, we've sent a checklist out to them this year, essentially because they've stood up this year, and they'll be identified by communities. I mean, a little while ago, some GPs weren't seeing patients with respiratory symptoms because of COVID. So we've targeted them specifically this year because they might have 10 people walk in and try and die on them, and they certainly need to be prepared. But every GP needs to be prepared. And that's part of, someone can walk in, clutch their chest and down they go. And, every practice, hopefully, is maintaining their skills, and they have a system involved to do that sort of stuff. Something's popped up. What we're hoping is, the forecast that goes out, the GPs are aware of the forecast. I don't know if they are. And they actually use the forecast to actually go, oh shit, it's a high risk day today in Melbourne. What does that mean for me? Okay, I have a little plan. My little plan is, my receptionist knows what to do. I've got, I don't know, a bunch of Ventolin sitting, over there. I've got a bunch of spaces. I know if 10, people walk in, this is how we're going to manage it. All the doctors know, the nurse knows what to do. And if it gets really busy, we're just going to line people up in chairs and give them Ventolin. Someone's going to call the ambulance if they need an ambulance, that sort of thing. So, and we could potentially, and I must admit, we have been thinking about that this year because COVID has got quiet. We now have an opportunity to reach out and do more this year, except the floods have come. That's holding us back a little bit. Yeah.
I was just going to say, Rachel's made a really good point there, because in the chat, if anybody's looking or wants to keep those resources, there's really great resources here, and it looks like there's a world of resources. And the asthma nurse community are doing brilliant things with their asthma clients. Sporting communities and schools, which we had touched on in our sessions prior to this, are difficult because that comes under Education Authority and how to reach into them. I suppose, as Rachel has pointed out very succinctly, it's all this information, how to make sure GPs are aware. And again, putting my hand up, I worked the event, I see lots of asthma, but I wasn't aware of most of the resources. A lot of it has been practicable things that I've learned through experience, through working through that. And in a busy day, it's not something that I would search for all the time. I feel like the Western health community is something that my patients now say, and this is just anecdotal, but they do say, oh, it was a stormy day and I didn't go out. I feel like that is something people kind of know about now. And for people who are practicing, if there's something to look at, that high wind that you described, really for me, I literally stopped in the middle of a consult to look outside because the trees were sideways, the sky had gone dark, and anybody who lives in Melbourne knows when a storm's coming, it goes still, goes hot, then the winds pick up. But this was another level. You knew something was happening, and within 2 hours we were flooded, absolutely flooded. So if you're worried about it, to say to your patients, definitely the high winds. But again,
but hang on. It's not just, we got to be careful. So it's not just high winds. There's severe storms that happen. Yeah, no problem. So it's a particular type of storm, and people just the past few days have been worried. There's high pollen, and there could be high pollen, but no storm, or not the right storm. So we don't want to. We've got to like get this right balance, because you know, it is the combination of the two. These big things, you know, it hasn't happened for like, you know, since 2016. So we want people to sort of, to have that, you know, the dual thing. You need pollen, you need to, I mean, the big things for me, and sorry, I had a bunch of other slides, but, you know, the take homes for me are, you know, we've got to manage asthma well. You know, if the thunderstorm asthma has hopefully been the tail that wagged the dog to get asthma sort of, you know, up on the radar. You know, we've got to find people with asthma, so get people with seasonal allergic rhinitis, hay fever, and see if they've got asthma and tell them they're at risk. And pretty much it's reasonable to assume that if you have hay fever in Victoria, it's probably from ryegrass. And if that's from ryegrass, then you're at risk. And what you should do is, avoid the winds before those big storms. Go inside. Think about asthma first aid. You've got to know asthma first aid. You've got to know what it is, and you've got to know what to do. And you've got to, you know, you've got to know where to have that little beta agonist. You know, so either get one or know where to get one. And you can get it from a pharmacy. You know, you don't need a script. And asthmatics, you've got to have an asthma action plan. ETSA should be on it. Thunderstorm asthma should be on it. And, you know, you got to take your preventer. No one died who was on a preventer. You know, it says a lot. And these were young, you know, I mean, young people dying from asthma is not, you know, dying from not being able to breathe is not very pleasant. And people watching it and helping, you know, some of those stories were really difficult to hear, you know, and, you know, so, and the last thing you want as a GP, you know, is a bunch of people walking in, not being able to breathe. You can't get an ambulance because they're busy and you don't have stuff. You know, like no one wants to be caught in that situation. Like it's not fair, and it's not pleasant. No good outcomes for that. So you know, the forecast is on Vic Emergency or on Melbourne Pollen. You can set up a watch zone on your phone so that it goes ping. There's a high forecast in the Mallee tomorrow, and lots of moderates. And the thing is, you got to distinguish high pollen forecast versus high thunderstorm asthma forecast. They're different. And the other thing is, forecasts are forecasts. We can get it wrong. You know, and we're the only people in the world doing this stuff in this way. And it's with events that are uncommon, it's really hard to you know, use the data to feedback the system. So at the moment,
I'm just mindful we've gone over by 10 minutes. So I was just going to say, Belinda, are you happy to share your the poll for this session? What we can do though is, if people are interested, and if Aaron and Danny are happy to stay on, you know, we can, if you have any questions, you can put it in the chat. Otherwise, we've just got a poll to just get some feedback from you about how this session went. And this will provide us with ideas on how we can run our future events. And also our next community of practice is in December. I think we've got the details here somewhere. Yeah, on the 7th, and it's about community asthma services. So if you're interested about finding out about what services are available, how you can connect to these services, the registered link is there, and we'll put it in that chat, in the chat, and also send it via email. And then the last thing also I just wanted to mention is that we've spoken a bit about the ICAM project. We are still looking for 2 more GP clinics to join us. So if there are any GPs online, or any practice managers from one of the following LGAs, we strongly recommend you to either shoot me an email or just even put your details in the chat, and I'm happy happy to connect to you. It's a quality improvement project, it's a pilot project, and it's just working with you to see how we can better improve the integration and service coordination of asthma care between different service providers. There is also a remuneration of a one-off $5,000 payment as well available to the GP clinic. But simply put your name and details in the chat and I'm happy to reach out to you and provide you with more information on this project. Do we have that poll? And yeah, any questions?
Sorry, if you did complete the poll in the first round that I popped it up, could you just quickly take a moment to re-answer those 3 questions? It shouldn't take long. And we really appreciate your feedback. You will also receive an evaluation form from the PHN. If you could take some time to complete that as well. We really value your input and your feedback, and it helps us build more productive community of practice. We want to know what inspires you and what you want to hear about to better manage childhood asthma management. The other thing, if you would like to subscribe, if you haven't already, to the ICAM newsletter, which shares up-to-date resources and some updates on the projects that are happening across ICAM, get in touch at icam@health.vic.gov.au, and we'll set you up. And I'm going to throw back to Catherine and Kirsty just to round us out for the evening, if that's okay.
I was just going to say, I just feel like there's still so much discussion and we could probably stay on most of the night, but I'm sure you will have better things to do. I think Kirsty and I will take it on board. I think we probably need to leave more time for discussions for future community of practice. But thank you everyone for joining in the discussions today. I've learned a lot. I've taken lots of notes too. And respond to some of the questions on the chat box. We will be putting all those links for you at the end of the session email.
And a very special thank you to Danny and to Aaron for joining us this evening to present such a robust and well-rounded 2 really great sessions that really facilitated generated some robust discussion. So thank you so much. And thanks for participating this evening, everybody.
Thanks for the invitation. It's a fantastic group. I wish we had something locally like this. Fantastic.
Thanks, everyone. We'll
thanks,
hang on
Dean,
the
for
line.
sharing your expertise, Dean. Thank you.
Yeah,
Thanks very much, everyone. Great discussion.